It's an honor to introduce Dr. Krishna Patel as our department's Grand Rounds guest speaker this morning. Dr. Patel is a full professor at MUSC, where she serves as Director of Facial Plastics and Reconstructive Surgery and co-director of the cranial facial team. She went to Columbia University, received an MD PhD from Medical College of Georgia, completed residency at the University of North Carolina, and fellowship in facial plastic surgery at UC Davis. She's a prolific academician, nearly 150 published articles, and serves on the executive board of directors for the American Board of Otolaryngology and Neck Surgery, and is also known just for being an incredible resident educator and mentor. From the people I've talked to, just have spoken so highly about her. Since her time as a resident, Dr. Patel has completed numerous medical trips to Central and South America to provide care and has developed a particular expertise caring for children with cleft lips, cleft palates, and ear deformities. She's currently on the board of directors of the Global Smile Foundation. And today we were fortunate to have her here to share the latest updates on cleft care. Thank you so much, Dr. Patel, for being here. We very much look forward to your presentation.
Thank you. So yes, thank you so much for the introduction. And I absolutely love San Francisco. I feel really honored to be able to come and talk to you guys. I wish it were in person, but I have the great honor of getting to work a lot with Dr. Muir and Dr. Knott at the national level and have a real love for your institution. So thank you. I am going to talk on, and can you guys see everything okay, screen-wise? Okay, good. I'm going to talk on cleft care and specifically the timing and the techniques involved. Here we go. There we go. And to me, this is something that I could talk days upon. So I'm going to try to really own it down in. And the kind of the main things I'm going to say that I want to talk about are that I'm going to very briefly hit on some anatomy, but really the big chunk of time is going to be is going to focus on timing of interventions and the type of surgeries and interventions that we offer for children born with cleft lip and cleft palate. I honestly hate hearing myself talk. And so I really do welcome questions. I know it's really hard in a virtual setting, so it might not be that easy, but feel free to stop me, call out, do whatever, because I would love to have the opportunity to answer any questions. I know we'll try to talk at the end as well. This is a very big passion of mine. I've done it my whole career. I trained at UC Davis where I got incredible training in cleft care. And these are some of the kids that I've taken care of. And I think one thing, if I can give you one message, is that I think when we think about taking care of children born with cleft lip and cleft palate, we think about the lip and repairing the palate. And then that, like, everyone's like, okay, yay, good for us. But that's really not the truth. The truth is that these three kids who I've taken care of, I will take care of all the way into their adulthoods. And that's actually what's so beautiful about taking care of children born with cleft lip and palate. You literally get to know them almost before they're born, all the way through into their adulthood. And it's a really special connection you have with these children, which is why I love doing it. It's for that reason also can be a huge challenge. Each child has different needs. And so it isn't exactly cookbook care. But thankfully there are guidelines. There's windows of time that you have to think about interventions. And so that's what I will try to go through today. And I think one of the things that you have to remember is that each child is different. So they have individual needs that you really need to address. And you also have to remember that it is multifunctional. There's many organs that are involved. Their hearing apparatus is involved, their ability to breathe through their nose, their ability to speak, and sometimes their airway. And so, like, you really do have to recognize that there's so many things that can be involved. And for that reason, it really does require more than just a surgeon. It's a multidisciplinary approach. And thankfully, in the 90s, our big institution that really oversees cleft care, it's called the American Cleft Palate Craniofacial Association. They recognize that. So prior to the 90s, a lot of children who were born with a cleft lip and palate literally would have to go and see these individual providers on their own. And then you can imagine that is really a huge burden to put on a family, and it's very disorganized care. And all of us know that it's really hard to communicate with outside physicians that aren't in your institution. So if you can imagine, these poor families were trying to figure out how to take care of these children. And so in the 90s, the ACPA said, okay, stop, we need to do this differently. We need to provide a multidisciplinary team approach where all of the specialists come together, sit down and meet these children and see them in one setting. And then we get together and we talk about what the care is, and we create or formulate a team plan. And so this is the list of specialists back in the 90s that the ACPA put forth. they just put out new parameters that essentially talk about similar things. And it's even better, I feel like, than what they had back in the 90s. But it shows you how many specialists are involved. And obviously, we are a big part of that. One of the reasons is, again, like, as I've already alluded to, is that every child born with a cleft is very different. So this is an example of even just the variety of cleft lips that can exist. You can have extremely mild clefts of the lip called microform, to incompletes where the nasal floor is intact to complete. But even though we're talking about lip, you can tell that even the nose is not symmetric, even in the most mild form. So when you look at these children, their care is very complex, and you have to think about that. Now, the reason this is just going to be 2 slides on anatomy that I'm going to talk about, but the reason that we really need to figure out how to take care of these kids as well as possible is that it's not only aesthetics, it's also function. So in a cleft lip, the biggest defect is that the orbicularis, which should be a sphincter around our mouth, just like our eyes are sphincters, our lips are sphincters, is disrupted. So the cleft goes through either one or both sides, and it abnormally attaches onto your columella and your alar base. And when that happens, it pulls your lip apart, meaning that you can't pull your lip into a sphincter, but it also disrupts your nasal normal anatomy as well. And your septum gets pulled because it doesn't have the equal vectors pulling on it. So your septum also gets pulled off to the non-cleft side. So the biggest goal when we do cleft lip repair is to really restore that sphincter function. A lot of people also ask, like, what else is going on in a cleft lip scenario? Well, I think there's a lot of debate about this, but a lot of people think there's deficiencies in some of the tissues and at every layer, meaning at the skin layer, at the bony layer, at the mucosal lining. The child on the left, it was somebody I met in another country, and you can tell he's had his repair, but he's clearly deficient of his columella, of his philtrum. And so you have to just ask, like, was that how he was born and they just put it together? Was that something iatrogenically done? My suspicion is that it probably does. It was a little bit of both. So I do think there's some deficiencies of soft tissues. The skeleton on the right shows you a child born with cleft lip and palate. There's definite hypoplasia of that maxilla on the right cleft side. So I think that does absolutely play a role in everything we're doing. And when I do rhinoplasties on these children, I think there's definitely deficiencies of mucosal lining, which makes it really hard because you're trying to get symmetry and restore normal anatomy. Now, like I said, so it's complex scenarios. So how do you learn the information? For me, I like to chunk the information. So I usually say the first step once they're born is to really think of growth and development. That's all I focus on. Next step is all your social components, getting the lip repaired, closing the defect. The next big chunk of information, like time that I think about, is their speech development. And then the last and the greatest part of their kind of treatment phase is just their dental and skeletal alignment. So and that's sequentially like through their age. So I'm going to go through that. Now, what I've created for my residents, because it is overwhelming, and these multidisciplinary teams are like a 3-ring circus. There's 6 to 7 different specialties there. And we're all trying to see the patients. And so when my residents go in to see these children, what they're going to say to a parent who has a 2-month-old is very different than what they're going to say to a child or a parent when they are 12 years old. So I did a Y kind of x-axis where the x-axis is your age, y-axis is all the organ systems. And like, I essentially tell them, okay, when you go in and there's a 2-month-old, look at all the things that you have to think about along those organ systems. Like, did they have genetics? What do they need for their lip, like a lip adhesion or a lip repair? Did they get feeding evaluation? Did they get NAM? Versus the 10-year-old, we're talking about bone grafting. I do this to help them organize what they need to think about as they're taking care of these kids. So this is like a really good way to break it up into the organs and think about what you're trying to address for these children. This is for me. So I'm sure you guys have heard this concept of butterfly effect, where you have this tiny little change in one part of the world that has some kind of chaos theory where it creates an unpredictable effect late in some other part of the world. And I do think in my head, there's a kind of a little bit of a butterfly phenomenon going on with these children where it's not so much unpredictable. I think there's probably a predictable component. We just haven't figured it out yet. But there are things that we are doing early in these kids' lives that is affecting and actually causing us to have to do more intervention later in their lives. And I want you to think about that, because your generation, as you're going through, hopefully can help us figure out what we're doing that can stop some of this effect that later we have to fix. So that is something I constantly think about because I don't think we have figured out the right way to take care of these children. And I think that we can do a better job. And I'm constantly trying to figure that part out. But we thankfully, due to technology, can detect cleft lips at least very early, even before they're born. So prenatal 3D ultrasonography has allowed for cleft lips to be identified, and it can be as high as 80+%. If a cleft palate is isolated, those are not usually detectable on ultrasound. So it's the cleft lip that's picked up, and then those families we can meet prenatally and start counseling them. And that is a very big advantage because it helps the families prepare before their child is born. Once they are born, the big things that I think about are airway growth and feeding, and I'll kind of break these down. So the airway evaluation is very important, and that is where otolaryngology really is very key. We always are involved in making sure they have safe airways. The speech therapy evaluation is about feeding and making sure they're feeding and thriving because you can't do anything if they're not. And then genetics is extremely important in all children born with cleft lip and palate. And the reason is that 30% of these children do have syndromes. 30% is a lot. A third of the kids that you see will have a link syndrome, and there's more than 300 syndromes. So I can tell you, I'm not going to be able to identify all of those. So that's where a geneticist is a very important part of the team. And now with all of the sequencing of the genome, we are finding more and more non-syndromic clefts linked. And so it really is an important aspect. And it's one of the number one questions I get asked is why does my child have this? Is it something I did? And it's a really important part of counseling families that this is a schematic, but there's an enormous range of environmental factors all the way to fully genetic reasons why children are born with a cleft lip and palate. This child, for instance, was born with heterochromia, had a bilateral cleft lip that I repaired, and then had a white forelock and had sensorineural hearing loss. So that's like a real classic one that we know, that's Waardenburg syndrome. So clearly I needed to get my neurologist involved, get my audiologist involved, make sure that they are adequately addressing his sensorineural hearing loss, which is the bigger part of what he needs to battle as he grows up. The other really important thing about airways I just want to hit upon is Pierre Robin's sequence, right? So Robin talked about this classic triad of micrognathia, glossoptosis, and airway obstruction. Now, some of those are actually turned into cleft palates instead of just being high riding palates. And that's because the tongue falls back during development. The developmental palatal shelves don't fuse, and they end up with a big U-shape cleft palate. So this is a big population that we take care of, and their airways are a really, really big part of that. And so in our institution, we do offer distraction osteogenesis. And there, I know in and I think at Stanford, Dr. Chu has done something called a non-surgical split orthognathic airway plate. So I don't know if you guys have ever looked at those airway plates, but that's something that's kind of a hot topic. But in our institution, we do distraction osteogenesis, where you essentially do a purposeful osteotomy of the mandible, put them on distractors, and slowly advance out the jaw. And you do this early in life to help avoid a trach and allow them to grow and feed normally. It's incredibly effective. The bummer is that sometimes these kids, this is not the only time they get jaw surgery. So, you only do this if you have to. This is a very delicate surgery that is a only as needed type of surgery, but it is one of the reasons that we should be involved in looking at their airways when they're infants or neonates. If they are not having such issues, then it's really about growth. And this is where the speech pathologists really are a very important part of their care. They are probably more important than any of us as far as getting the child to feed. And if you have an isolated cleft palate, you should not need an NG tube. So this is a no-no. There is no reason an isolated cleft palate should get an NG tube. Now, if they're syndromic, have hypotonia, other reasons, that's different. But otherwise, they really should be able to be fed with any of these specialized bottles that are on the left of the screen. We like Dr. Brown's. It creates like a negative valve or one-way valve system. So the baby just literally just has to like munch on the nipple and root, and it will naturally pull in the milk without them having to create suction. So the number one thing that babies cannot do when they have a cleft palate is create suction. If the way I often tell parents is if you try to drink through a straw, that's great. If you put a big hole in the straw and you try to drink through it, it's miserable. You're creating so much effort to get stuff up through the straw because you do not have a closed system. And that's what these babies are like. So they look like they are able to root and suck, but the amount of calories they have to expend to actually get the milk into their mouth is so much effort. They spend more calories actually trying to feed than they do actually, getting from the nutrients that they start to get failure to thrive. So truthfully, if you have a cleft palate, you really need to have a specialized bottle. Moms get upset about this, especially from a breastfeeding standpoint. So we usually say, okay, feed your child, give the nutrients, then you can bring baby to breast for like bonding, but you should not rely on that for actually getting the nutrients. So that's like the biggest part, growing and feeding. Once we get that under control, then we really push to address the lip. And this is the social component. So I have, in other countries, I do cleft lip repairs in adults, but in this country, thankfully, they get done very early. And that's a social phenomenon that happens in our country. But there are some things that you want to look at or offer that to do to get them ready for their lip repair. So there is something called nasoalveolar molding or taping. And then in this time window from birth to 6 months, we usually do the lip repair. And then sometimes we address their ears and put ear tubes if they have a cleft palate, because they usually have eustachian tube dysfunction. So what is NAM, or why do we do NAM, nasoalveolar molding? So this is a child born with a bilateral cleft lip. And you can tell that the lip, which is out, can y'all see my arrow? Is that visible? Okay. So the prolabium is the lip. The premaxilla is the maxillary component of the bone. And that's this whole little segment right here. If this is in y'all's way, it's in my way. Let me get this out of here. This whole segment here is really pulled out because it has no forces keeping it in the mouth. So if you can imagine, if you try to get the lip close to that lip, that's a huge amount of tension on a lip repair. So what we offer is to do what's called taping if they can't come for nasoalveolar molding or nasoalveolar molding. Taping is essentially literally tape pushed across the lip. It is not very controlled, but it does get this premaxilla and prolabium into the mouth. NAM, nasoalveolar molding, is essentially a device. It looks like a palatal device that you make an impression in their first week of life and you essentially put it into the mouth. And so you are trying to slowly adjust. It's like braces. And so you can slowly adjust the device as it's in the mouth over weeks, and it essentially pulls the premaxilla into the mouth and pulls the alveolar arches, which are on the side, out so that hopefully we have a better alignment. So this is a really incredible device. The people who are proponents for it do not think it causes any kind of scarring mid-face hypoplasia, as opposed to, and it's called passive orthopedics versus active orthopedics, which might cause some hypoplasia. So sorry, I keep touching things on the screen. So this is just kind of a schematic version of that. So if you look at this is a schematic of your alveolar arches where your teeth come in. In a unilateral cleft, you've got your bigger segment that has your premaxilla and your arch on one side, and then the cleft, and then what we call your lesser segment on the cleft side. And if you just push this down, like with taping, you can sometimes have this uncontrolled closure of your alveolar arch where it's not aligned well. And NAM, the goal is that you can get the arch really well aligned, and that really plays a role in palatal repair and their need for braces and their dental alignment of their teeth. So it's really important if you can do it. It's a very intensive process. Now, this is an exact example of a butterfly effect. If we do this early on in their lives, either through taping or through just letting the lip close and push these pieces together like this, we have done a poor job of not getting them set up for success for their braces, for their bone grafting, and we then have to expand them out. So this is where we have to be creative and make sure that the surgeries that we're doing early on are in a very controlled fashion that set them up for success later. Nasoalveolar molding is, like I said, a braces technique where you're just tightening things down. And this is Dr. Grayson, who is the one that really invented it. This is an example of one of his kids where you literally go from a wide cleft to a cleft that's almost touching if you do the device well. So once you do the NAM, get everything as good as you can, and not all kids need it, but the kids that have wide ones, they do benefit from it. Then you're closing the lip. And so typically I do the rule of tens, which is that I want them to be at least 10 weeks old. I want them to be 10 pounds. That's the thing I care the most about. And then this concept of 10 hemoglobin is relevant in other countries. I've seen where babies had hemoglobins as low as 5, and you've got to make sure their nutrition status is up before you actually want to try to repair their lips. So that is a really important thing in other countries. But for me, the 10 pounds is the biggest thing that I think about. And so the repairs that what we offer are wide range, and I can show you a list. The one that I do is called a Fisher subunit repair, but the most popular one is called a rotation advancement or Millard repair. And then they're all beautiful. I was trained on the Millard. I love them all, but I've just converted for various reasons. So what are the goals of the cleft lip repair? So the goals, I think I already mentioned the biggest one, which is your orbicularis needs to get reapproximated back into a sphincter. So that's one of the biggest things. The other thing is that you're trying to get your lip height as symmetric as possible, meaning your Cupid's peaks. You're trying to get your vermilion roll, and this child doesn't really have much of one, but like it nice and smooth. You want to get the scar to camouflage as beautifully as possible, and you want to try to get the nostrils as symmetric as possible. So those are all things you're thinking about when you're doing these repairs. That is easier said than done, which is why this is how many people have described cleft lip repairs, because there is no definitive way to do this. And you can tell because these are all really famous surgeons that have tried to get a better version. And there's a reason for that because we really have not perfectly figured it out yet. So the question really becomes, which one are you going to do? So are you going to do the one that your mentors taught you in your training? Are you going to go to PubMed and look out like who's got the best results coming out of PubMed? Are you going to be influenced by the influencers on social media? Like these are questions that you have to ask yourself. And I can tell you, I started off with a Millard and I converted over to a Fisher. So these are things you should challenge yourself as you go through your career. What they have found though is that really truly, if you learn one technique really well, you can really control your outcomes. And so most surgeons stick to a single technique throughout most of their career. Since I know that you guys sometimes I don't know how much you get exposed to actual lip repairs. Millard rotation advancement is the most popular. It's a beautiful repair, and the concept is that you're rotating the side that has the non-cleft down, and you're advancing the lateral lip over. So that's why it's called a rotation advancement, and it has essentially 10 points. Fisher subunit, which is what I do today, has 25 points. And many people are intimidated by this repair. It's actually a lot more straightforward. It takes some of the artistic level out of it. It's much more mathematical. And so for me, the way my brain works, I like the subunit repair better. Millard is a cut as you go. So you have to have a very good eye and very good artistic kind of technique if you're going to do a rotation advancement Millard. But once you get the lip repaired, you've kind of dealt with that social component. And now we're really moving on to speech and swallowing. And so, and it's really speech. I say swallowing only because when babies feed with an open cleft palate, food comes out their nose because they have an open communication there. But it's speech. That is why we do cleft palate repairs, is for creating normal speech. If you have an open cleft palate and you don't repair it, you will not be understandable. You will have what we call VPI, where it sounds like this and you have air going through your nose. It is not speech that is understandable. And then you start creating what we call compensatory habits to try to make yourself more understood. And then that's a nightmare because then you have to untrain those habits. So this is the really hot topic of cleft is when do we fix these palates? How do we fix them? How do we prevent all the speech issues? And so usually I would say most of the country repairs cleft palates somewhere between 9 to 12 months of age. There's been studies that suggest that after 18 months, and some people are now saying even sooner than that, if you don't repair soon enough, these children develop compensatory problems, and they're really hard to unteach as the kids grow up. So you do want to establish their anatomy pretty quickly. However, the earlier you do it, There's a debate of how much hypoplasia you're causing, because when you do essentially elevate the hard palate tissue, you're creating a ton of scarring on their palate. So then the counter argument to going early is that you create a lot more midface hypoplasia. So you do have to balance it. And I think most of us try to do it around 9 to 12 months. And that's also when we look at the ears, they have eustachian tube dysfunction because their palatini is not intact either. They're tensor palatini, and so they don't open up their eustachian tube as well. So usually these kids need ear tubes until their palate is repaired, and then they start to function more normally in their eustachian tube. So again, that's the butterfly effect, just talking about the scarring and the timing. This is where I think we have not quite figured out the right way to address the timing of their palate, how we fix their palate without creating all this hypoplasia or problems down the road. Now, what is it that we do? So this is a picture of normal anatomy and then a cleft palate. And you can see that your levator villi palatini, which is this big muscle across here, is not oriented correctly in a cleft palate. It's abnormally inserting onto the hard palate edge. And so that does not elevate the way your palate raises. When you say ah, your palate raises, your soft palate closes off your nasopharynx essentially. When you've got it vertically oriented, it cannot do that. So the biggest goal is to take the vertically oriented palatal musculature and turn it horizontal. So you have to detach it from the hard palate and then push it horizontally. So that is the whole goal of a palatoplasty. Now, the old techniques literally just did a straight line incision along the entire edge and just pulled it together. The Furlow describes something called a double opposing Z-plasty. And the beauty of that is it detaches the muscle, it turns it 90 degrees and closes it. Now you can do that in what's called a straight line closure, but you have to do something called an intravelar veloplasty where you pull the muscle horizontally and close it. The one advantage of a Z-plasty over an intravelar veloplasty where you've pulled the muscle horizontally, you can't just see it underneath here, is that a straight line closure shortens palatal length. A Z-plasty, as you guys all know, Z-plasties lengthen. So you get not only the muscle in the right orientation, but you lengthen the palate, which is very important for speech. And so this is an example of what it kind of looks like. It has a zigzag kind of appearance in the soft palate. In the hard palate, you're just closing it straight line like you would normally in a straight line closure. So palatoplasty is the key surgery in getting right. Once you've done that, you start to let the child develop out their speech and you start to really pay attention. And we are very aggressive about doing speech therapy early. We advocate for it because this is the time to break any bad habits they've started and make sure they are learning how to speak properly on their palate. So we start doing what's called velopharyngeal evaluations. Velo means palate, pharynx means pharynx. So we're looking at their ability to raise their palate, close off their pharynx for good competency. If they can't raise their palate off and close off their nose, that's called velopharyngeal insufficiency, VPI. That is a problem. And probably that's another butterfly effect where if we did not get the palate closed properly, if there's something we are doing early on, we are potentially causing this VPI. Now, we're not the only ones. There are other reasons why children have VPI. 22q11, they have significant hypotonia. There are a lot of syndromes that are predisposed children to have VPI. It's not just the technique, but a lot of it is technique. So that is where I feel like we really need to be smarter about how we're doing repairs. Once you get them through all their speech therapy, and let me just backtrack for 1 second. If they do have VPI, this is the age range that we start doing what we call speech surgeries, which is pharyngeal flaps, sphincteroplasties, palatal lengthening with buccal flaps. That's a whole nother lecture, but there are lots of things we can do to recreate velopharyngeal competency. And this is the age that you do it because you don't want them going to school and not communicating well. So you try to catch them before they go and matriculate through school, get them speaking as normally as possible, because that's a really big thing that they have to face in school. Once they're in school, it becomes a social thing again. Do they feel like they look acceptable? Are they functioning normally enough to go and just go out into the world? And so this is sometimes when we look at doing intermediate rhinoplasties and lip revisions. And so this is an example of why we would do an intermediate rhinoplasty. So it's called intermediate because when we do the lip repair, we oftentimes do address the nose. It's part of the asymmetry. So that's called a primary rhinoplasty. I do septal repositioning at the infancy, which is not a septoplasty, but it's repositioning the septum straight. Intermediate rhinoplasties, what you're trying to do is really reserve those for really severe defects where they're either causing so much nasal obstruction the kid's not functioning well, or they're just socially getting bullied. In a bilateral, and I can't tell if this is blocking y'all's view or not. I'm sorry. I'm not being very good at this. In a bilateral, the premaxilla is oftentimes foreshortened at the columella. And a unilateral, it's usually an asymmetry thing. So these are two kids that I repaired. And then after the repair, you can see this is my bilateral child. She's very foreshortened in her columella. So I will probably have to lengthen her columella at some point when she's a little bit older. And then this is the asymmetry that you see in the nose. Now, I usually try to talk parents out if it's just mildly asymmetric, but sometimes the parents really want it. So this child is one of my kids. I really was pushing to not do anything. He was getting bullied. So I opened up his nose, and you can see that his domes are definitely two different heights. So essentially I do a very limited open approach. I sew the domes up with some cadaver cartilage and try to get the nose as symmetric as possible. But even then it's not perfect. So, you limit your intermediate rhinoplasties to only those who really, really push for it. But so that's kind of the soft call, like whether we need to do those intermediate surgeries. I try not to. I try to get my repairs as pretty as possible so that parents aren't asking for that, but sometimes they do, and it's a fair thing that we have to address. Once you get them to their kind of tween years, now it's all dental. It's dental and skeletal alignment. And this is where your orthodontist, your dentist, your oral surgeons, they're very, very important. The things that we intervene with are distraction osteogenesis, orthodontics, and then alveolar bone grafting. So this is again where if we have not done those palate repairs well, we're now asking our orthodontist to get the teeth into the right position, get the arch into the right position, put them in expanders. And so that's again where if we could just be a little bit better early on, we could avoid some of this. So when they are young, they get put in palatal expanders, because if there's any hypoplasia of their maxilla and their arches are not perfectly aligned, their expander pushes their teeth out, kind of corrects that malalignment. Then, and that's essentially correcting a crossbite. Then you come in with the bone, put bone in that gap, and then you put them back into orthodontics with braces to move the teeth into where there once was the cleft. If you put bone graft too soon, you impact the teeth from erupting. If you put it in too late, the canine will come loose and fall out. So you do have to balance the timing of this, and that's really, really important. So this is all a time thing. There are windows of opportunity, and this is one of the biggest ones for these kids. You really have to watch their dental growth and choose the right time to do their expansion and their bone grafting. Distraction osteogenesis is exactly what we did to the mandible when they were infants, but now you're doing it oftentimes in this like tween years, which I don't like to do. This is only if you have to, but you can see this child had very severe micrognathia, and it was affecting him socially, and he could not pull his lips together, so his speech was not normal. So he got distracted, and usually it's reserved for really severe occlusion discrepancy, so greater than 12 millimeters. But the bummer about this is if you do this when someone's like 10, they will relapse as their mandible and maxilla continue to grow, and then they end up having to get again another surgery when they're older. So again, reserved for really severe cases, and ideally if you're going to do it, you ideally do it when they're fully skeletally developed. But if you can't, this is acceptable to do, for instance, in this child's scenario. So then the last phase of life, which is one that's really fun for me because it's where I kind of come back in. I do a lot of their cleft surgeries, and then I kind of stand in the background, and then I come back at the end. It's just the rhinoplasty, but you cannot do rhinoplasties until their skeletal alignment is corrected. So they've gotten their bone grafting, now they've gotten their braces, and now it's about, is their jaw correct? Do they have good alignment of their maxilla and their mandible? If they don't, you get them skeletally mature, which is usually 16 to 17 in women, 17 to 18 in men. And then they either get orthognathic surgery or distraction osteogenesis. And if it's a mild shift, then usually it's orthognathic, where you break the bones, plate them, because you're not moving the bones too far apart from each other. If you need to do a huge change, then you would not be able to do orthognathic surgery. It'd be too unstable. So that's when you do distraction osteogenesis, where the bone can kind of grow and expand them out. But once you get their skeleton aligned, then you do the rhinoplasty. If you do the rhinoplasty before, then you risk the nose completely changing after orthognathic surgery. The timing of, so the timing of this is very important. They just have to be skeletally mature. And about a quarter of children who have a cleft lip and palate need some version of an orthognathic surgery. So it is a pretty big population. And this girl is an example. She had a very severe cleft. She actually was treated outside our institution and actually lost her philtrum. So we ended up having to do an abbé, and it not only helped her philtrum, which you can't see in this picture, but it also, her nose was severely pulled in. So it pulled her nose out. But then she grew, she got to be a teenager, and she got her severe class 3 occlusion corrected with orthognathic. And then her tip was still in. So then we pulled out her tip with a rhinoplasty, and she's kind of healing from that. So I literally just took you from babies all the way to adults, but hopefully I think I'm in my time window. But this is essentially an incredible journey that you take with these kids. It's really fun. It definitely involves more than one person, speech, us, all, so many surgeons. And it's one of the most gratifying things that I probably do in my career. So it's a real passion that I have. This is a picture of Charleston. So I know y'all have beautiful sunsets over on the West Coast, but I just want to remind you the East Coast is also beautiful. So feel free to come and join me anytime.
Thank you so much, Dr. Patel. That was incredibly comprehensive, helpful from the resident perspective and from faculty. Both have been getting messages about how wonderful your talk was, and it was just really wonderfully presented. So thank you so much. I will. We have time for questions. So if people have questions, please raise your hand. And I'll go ahead and call on you, and we'll organize ourselves that way. I'd love to kick us off. I have two quick questions for you. Could you describe? I recently had a discussion with Dr. Knott about the challenges of secondary rhinoplasty for children who have cleft palate, and the vestibular tissue deficiency, the difficulty of really trying to reconstruct the asymmetric domes, and kind of where you how you do that. Can you kind of share your pearls for secondary
Yeah.
rhinoplasty and what things you like to think about?
Absolutely. And Dr. Knott's totally right. I will have to say I do a lot of rhinoplasty, and some of the hardest rhinoplasties I do are what you call cleft rhinoplasties. And it's for the reason you literally just hit upon, which is the tricky part that people don't understand, is it's not really the external skin that's the problem. It's all your internal lining that really limits you. And there's so much memory to these kids' noses that you're kind of combating internal lining deficiencies on top of having just that memory of that skin. So I think the biggest flaw is that people try to like put all this, they try to prop up the nose, do all this skeletal like grafting and stuff. But if you don't make sure the internal lining travels with all this grafting, then it just tries to pull back down into that asymmetric nostril. I think without a doubt you need grafting. It's not one of those patients where you can try to tweak things and trim and contour with suturing. To me, cleft rhinoplasties always require some version of a very strong grafting. And then I'm constantly having to try to figure out how to get the internal lining to travel. I oftentimes do what's called a V to Y, where I actually release the internal lining at the vestibule and advance it up like a lateral curl steal, and then close the internal lining in the Y part, but you can give alar retraction from that. So they're like, it's not as simple as just doing a V to Y to the internal lining. But it really is, it's one of the hardest things I do, but hopefully that gives you a concept at least.
That's good. Thank you. I think Dr. Muir has his hand raised.
Yeah.
Yeah, Krishna. So I noticed you quoted the McCarthy paper. I think he was at NYU, McCarthy,
Yeah.
and about the early osteo distraction technique. And I just wondered, I was thinking about that, like how do you avoid disrupting the tooth buds at that age? You're going to have to put that thing on. Clearly, it's got to be monocortical, and I just don't know how you're going to avoid that.
Right. So for nasoalveolar molding, there is no set that it is literally an appliance that you put in your mouth, and it literally fits like a glove, and they slowly build it out. And so it's called passive because you are not actually stabilizing it to the bone. It's
No, I'm talking about the distraction
that's yeah.
osteogenesis.
Oh,
Yeah.
yeah. No, you definitely disrupt. Sorry, I'm sorry.
Mhm.
From the distraction, osteo distraction, that is why mandibular distraction is so tricky in children. Without a doubt, when you counsel these families, you have to tell them that tooth bud disruption is a real risk, and it
Mhm.
100% is. Now, usually you're trying to go posterior to where the buds are. And so like you're hoping that you can miss them, but 100% that is a known risk of the procedure. And the other thing that's really frightening about that procedure, if you've ever done distraction osteogenesis, is that babies' bones are like butter. They are not like adult bones. And so you put this device on and you start distracting it, and the device can actually like feed through the bone. Like it is technically actually a really challenging thing to do. But yes, you try to get, because the buds are really along the lower portion of the mandible. So you try to get posterior to that.
Got it. Thank you.
Sorry.
I have one other quick question for you, Dr. Patel's other
Yeah.
question stream in. Could you talk about how you really kind of hit on the importance of monitoring VPI? Can you talk about how you surveil that in your clinics? Is it scope? Do you guys use validated scales to kind of look at this family's perspective? What do you
Yeah.
guys do to do that?
So that is actually one of the hardest things to figure out, is like what's the best way to evaluate these kids. And so our speech therapists, first of all, are very involved in their care early on. So they start to really understand how these kids sound and like talk to them enough to kind of be able to identify certain hypernasality or resonance issues. But the way we evaluate them in our VPI clinic is we actually do nasopharyngoscopy. Like we stick a camera in their nose. It is very hard because this age we're usually doing this in 4-year-olds, 5-year-olds. And if they are non-compliant, it can be just miserable. And that's a pretty big group of our kids. Like they hate it. There are other people who do fluoro. We do not use fluoro to evaluate because it's radiation exposure, but it's certainly, there's a lot of cleft craniofacial teams that do use fluoro. There's also now dynamic MRI that Jamie Perry, who's like the editor of the ACPA journal, she has a grant looking at using dynamic MRI to look at the musculature and the motion of it. We still really just heavily rely on scope exam and try to just like, and this sounds terrible, but like literally just kind of hold the kids down, get the scope in, get them to start talking, crying, whatever, and just look at the function back there and see if we can tell what needs to be done. Because you do really have to understand the closure patterns to know what the correct way is to manage their VPI.
Thank you.
I do wish there were a better way though. Honestly, like if someone could figure that out, that would be amazing. Because it really, the kids are really traumatized by it. I would love to say that that's a pleasant visit, but it's not. Like I do feel like I struggle to make that a visit that the kids don't really feel traumatized by.
I think those are our questions so far. One last question for you, Dr. Patel. I know kind of in our adults for VPI, for very different scenarios, people are using filler as kind
Yeah.
of either a temporary thing or as something as an alternate to doing some sort of procedure to help kind of recreate that tissue deficiency. Do you see any sort of role of that in cleft and kind of how would one incorporate that into the practice?
Yeah, we absolutely will offer filler. We use deflux, which I don't know if what you guys use in your adult crew, but deflux is used for urethral reflux issues, and we've found it stays decently in the nasopharynx. So when you have a really subtle gap there where you just need to bump a little bit of the nasopharynx and you don't want to do a really big surgery, then we will do filler injections in the nasopharynx. I will, and honestly, I don't like VPI surgeries. I think that there's a whole component of sleep apnea that you have to worry about that we might exacerbate. So small procedures like fillers, if that is doable and we think it'll achieve the goal, we absolutely do that.
Got it. Thank you.
Yeah, thank you. Thank you guys for being this early with me in the morning in California.
We so appreciate you being here, Dr. Patel, and kind of giving us this presentation. It was very, very helpful, and very grateful for you making the time. So thank you so much. Came highly recommended. Many of the faculty speak highly of you, so it was just wonderful to have you and host you. So thank you so much.
Yeah, thank you.
Krishna, thank you. See you soon.
Yes,
Thank you,
absolutely.
Krishna.
Thank you. Thanks, Dan. Bye.